Hi friends, I welcome you all for this session. We all use serum screening or NIPT whenever required for the patient. But in this era where we use both, is there any role for soft markers or serum analytes? Is what we are going to see. In this video, we are not going to discuss about the screening tests that are available. But before we proceed to whatever discussion we are going to have, I thought it's better to brush up the detection rate once. We know that the combined screening test and cell-free DNA has a high sensitivity of 90 and 99% respectively. And still, even now, many patients end up in doing second trimester screening tests like triple or quadruple screening test with sensitivity of around 65 to 70 for triple and 70 to 75% for the quadruple screening test. Nowadays, first trimester scan and combined screening test using the biochemical parameters is used as a universal screening test. Even the non-invasive prenatal testing is widely available. In many places, non-invasive prenatal testing has become the primary test of screening. However, non-invasive prenatal testing is not affordable all the time. In my center, where I use traditional combined screening test, I categorize the result into low risk, intermediate risk and high risk. The risk cutoff used in our lab is 1:250. High risk patients have the risk of more than 1:250, whereas the intermediate risk falls between 1:250 to 1000. And when the risk is more than 1:1000, it becomes the low risk. So the low risk category, where the risk is more than 1:1000, we do routine prenatal care. In the high risk category, where the risk is less than 1:250, we are going to offer the patient invasive testing. If the risk falls between 1:250 to 1:1000, then that becomes the intermediate risk category. And for these patients, we give the option of non-invasive prenatal testing. If the NIPT test result is screen negative, then we continue with the routine prenatal care. And in case if the NIPT result is positive, then we offer them the invasive testing again. The main objective of this video is not to tell about the various screening options that is available. I come across lot of referrals in view of soft markers even after doing combined screening test or non-invasive prenatal testing. What to do in those cases is what we are going to discuss in this video. The main referral article for this discussion is going to be the article that I have shown here, and another article of SOGC guidelines will be shown at the end of the video. Now let us see a little bit about the LR. LR is nothing but likelihood ratio. LR is to say how likely a test result is to occur in a patient with disease compared to a patient without the disease. Here the disease in our discussion is going to be the aneuploidy, especially the trisomy 21. Larger the LR, more likely is the disease, and LR will be less likely to vary with the prevalence of the disease. Most of the soft markers that is discussed in this paper are categorized based on the LR, with small increase in likelihood of the outcome is between 1.5 to 5, and with moderate increase is between 5 to 10, and significant increase is in the range of more than. I have summarized the various markers and their likelihood ratio and what to do further into a simple table so that it is easy for interpretation. We see the echogenic intracardiac focus. The LR is almost less than 1, which means that it does not increase the a prior risk. If the patient has not undergone any aneuploidy screening prior and we don't know her aneuploidy risk, then maybe we can give the option of NIPT or quad test. But if she had done serum screening or NIPT test and that comes out to be low risk, and in presence of echogenic intracardiac focus, we need not do any further testing. Do we need to follow up the patient to see if echogenic cardiac focus is disappearing or what is not required. Next, when we come to the choral plexus cyst, it is a marker for trisomy 18 and not for trisomy 21. So the same thing applies to this. So if the patient has not undergone any aneuploidy screening or for NIPT or quadruple test, if the serum screening test or the NIPT test done prior is low risk, then we need not do any further testing, and antenatal follow-up and management or nothing specific for that, because this is going to disappear most of the times as the pregnancy progresses. So we need not even follow up. Coming to the echogenic bowel, some studies show that the LR is 6 to 8, and one of the meta-analysis shows that the risk is LR is 1 is to 6.5. So if no aneuploidy screening, then NIPT or quad. If the prior screening test including NIPT is of low risk, then we need not do any further testing. But however, small percentage of it may be echogenic bowel may be associated with cystic fibrosis or infection or intraamniotic bleeding, which we have to have in mind and keep them under antenatal follow-up. And when required, we can offer them investigation for the same. In case of single umbilical artery, there is no increased risk for aneuploidy if it is isolated. However, if the aneuploidy risk is not known prior, then we can give them the offer of NIPT or quad test. If they had done it previously and it has turned out to be low risk, no further testing is needed. But we know that the single umbilical artery can be associated with evolving anomalies including GIT and GUT. We need to follow up them for changes as the pregnancy progresses, including the evaluation of perianal musculature complex becomes very significant in these cases, and they are more likely to be associated with growth disorders also. So it is very important that we follow up them for the same in the third trimester. Now if you look at the urinary tract dilatation, the LR is 1.5, and if the aneuploidy screening done prior is of low risk, then we need not do further testing, and if they have not done any type of screening test, offer them NIPT or quad test. We need to follow these patients to look up for the progression of the dilatation, and if possible, we can go for the diagnosis antenatally. And sometimes it may not be always possible to find out the etiology in the case of UTD. So we need to have early postnatal follow-up in case of significant progression in the dilatation. If you look into short humerus and short femur, the short humerus has more LR than the femur, can be in the borderline in many of the other causes also. Now, if the aneuploidy screening is not done prior, we can give them the offer of NIPT or quad test. Had they known the aneuploidy risk, and if it turns out to be low risk, then we need not do further testing. But however, we need to follow them for growth, as they can turn out to be skeletal dysplasia anytime in future. I have been referring to serum screening often in this slide. If you wonder what is it, it includes all the type of maternal screening tests like first trimester combined screening, integrated screening, sequential screening, contingent screening, or any quad screening. All the LR that we discussed in the previous slide are applicable when they are present as an isolated marker of aneuploidy. Now, nuchal fold thickness and absent nasal bone have a relatively increased LR. Now, if they have not done any previous screening test, we can offer them if the serum screening or NIPT that they had done prior is of low risk, and then you have this marker, still you can give them the option of NIPT or invasive testing. If the NIPT is negative, then no further aneuploidy evaluation is required in these cases. To summarize, if we have increased nuchal fold thickness or absent nasal bone, then we need to give the option of NIPT, quad, and also the invasive testing to the patient. So that has to be kept in mind always, and it has to be an informed choice from the patient side. So we need to give the all information, including the detection rate and the significance of this marker. And if the patient opt for whatever test they prefer, that can be proceeded with. Invasive prenatal testing or quad test or invasive testing also can be given as the option to the patient. We have seen that in the previous slide that echogenic small bowel is associated with the increased risk of cystic fibrosis, fatal infection, or GI malformation, and whenever required, we need to investigate for the same, and we need to have a close monitoring of these fetuses in the third trimester. We have seen already that hypoplastic or absent nasal bone is associated with a relatively high LR in second trimester. It is also found to be associated with increased risk of having pathogenic copy number variation or sex chromosomal abnormalities. In the case of mild ventriculomegaly, the risk of having copy number variation is 5%, and it is up to 16% if the ventriculomegaly is going to be severe. Ventriculomegaly need not be a marker for trisomy 21 alone. It can Now when we consider the short long bones like femur or humerus, as far as the aneuploidy screening is concerned, when do you say short humerus? When the ratio of observed to expected humerus length based on the biparietal diameter is less than 0.9, then you consider that humerus to be short for aneuploidy screening. A femur is considered short if the ratio of observed to expected femur length based on BPD is less than 0.92. However, if the long bones fall between -2 to -4 standard deviation, we should always have skeletal dysplasias or other reason for having the short long bones. Hence, we should do karyotyping and chromosomal microarray if the long bones fall between -2 to -4 standard deviation. Isolated ARSA, the option depends upon the prevalence in the population. In our center, if the patient has undergone prior serum screening or a non-invasive prenatal testing, and if ARSA is present, then we don't do any further testing for the aneuploidy. However, if patient has not undergone any type of screening, then we give them the option of quad or non-invasive prenatal. One of the main reasons for this video is even now there are a lot of referrals for this individual serum analytes being in high MOM or in low MOM. How to proceed with them? What is the cutoff MOM that is significant? Now let's see one by one. Regarding low Papier less than 0.4 MOM, there are a lot of studies saying that it is associated with fetal growth restriction in the late trimester. And I think all of us are aware of this low Papier MOM. But what about the other analytes? Beta HCG less than 0.5 or more than 3 MOM is found to have association with adverse pregnancy outcome. And alpha fetoprotein of less than 0.25 or more than 2.5 and inhibin more than 2 MOM or estriol less than 0.5 MOM have been shown to have some association with the adverse perinatal outcome. But there are no adequate evidence of these analytes having clinically significant adverse pregnancy outcome, and hence they are not currently recommended as an individual serum marker for screening for adverse pregnancy outcome. But low Papier is significant and it is used along with PLGF for preeclampsia screening. Now regarding serum alpha fetoprotein, more than 2.5 MOM as a screening tool for neural tube defect is no longer necessary, because nowadays we do very good ultrasound, targeted ultrasound to rule out open neural tube defects. If you find any fetal structural abnormality, regardless of the previous screening test result, be it NIPT or first trimester combined screening test or quad test, whatever it is, we have to counsel the patient and offer them invasive testing for the rapid test as well as for the microarray. So the confirmatory test that is available is chorionic villus sampling and amniocentesis. The risk of miscarriage for CVS is 1 to 2 and for amnio it is 0.5 to 1%, and their sensitivity is close to 100% for both. If we don't have any markers to indicate invasive testing, but if the couple wants to know the chromosomal status of the fetus, they have all the right to undergo invasive testing. This should always be kept in mind. I hope this video was useful for all of you. I think it will definitely clear some of the doubts that you might have. If you like such videos, please do comment. Then maybe I will upload videos like this. Thank you for the support you have shown so far. I'll meet you soon in the next video. Thank you.